Hi, everyone, and welcome to another amazing edition of NextGenMD. This topic was by popular demand, or should I say, maybe not so popular, but yet major demand. It's all about statins, and it's not controversial when it comes to physicians and clinicians, but when it comes to patients that have cardiovascular and vascular disease, there seems to be a lot of debate over whether or not they should be on them, the implications of being on them, the good, the bad, the indifferent. There are so much information out there that patients really don't know which way to go. There are even Facebook groups. Dr. Johnston, Dr. Lily Johnston, vascular surgeon from Southern California, here with me, always with me with NextGen MD, my amazing co host. Sorry to throw such a crazy topic at you, but we've got to break this down for patients. They have so many questions, about statins. They need more questions to have a more productive conversation with their doctor about these statins so they're more informed and they can feel more confident in the care they're receiving and the medication they're taking. But I'm going to throw it to you before we get to uh the I would say the firing squad. Lots of questions came in on this topic. I'm sure more to come, but I'll start with you. What is your opening statement on statins?
Thanks, Kim. Pleasure to be here as always. What I would say about statins for anybody with a diagnosis of peripheral arterial disease, coronary artery disease, carotid disease, anything where we know they have plaque in the arteries. The guidelines here are quite clear that once you have that diagnosis, high intensity statin therapy is recommended to achieve a greater than 50% reduction in your LDL-C, LDL cholesterol. Is that the best measure? We don't know. ApoB is emerging, but all of the clinical trials that have been done include LDL-C or LDL cholesterol as the marker. So that is what the guidelines use. And notice I said a greater than 50% reduction. Doesn't really matter where you start. So we want to see that 50% or more reduction with the use of high intensity or maximally tolerated statin therapy. Now, the goal here is ApoB reduction. Statins are but one of several options we have in our arsenal to achieve that. And we can certainly talk more about what the other options might be, risks and benefits of all those agents. But overall, if you have this diagnosis, P.A.D, coronary disease, you should be on an aspirin and you should be on a maximally tolerated statin therapy or other therapy to lower your LDL-C greater than 50%.
But doctor, my cholesterol is normal in a basic lipid panel. Why am I on them?
If you have a diagnosis of PAD or coronary disease, you are on it because it is guideline medical therapy to lower your LDL-C by 50%, no matter what that starting value is.
And if you have normal cholesterol in a basic lipid panel, that doesn't mean that your cholesterol is necessarily normal. It may take looking at not just the quantity of the LDL particles, but also the quality, right?
That's right. We have the particle count, which is more informative. Also, we'll be looking at particle size and other particles like LP little l talked about. We don't know about your triglycerides and your HDL, which, as we mentioned in a previous episode, is really more indicative of your metabolic status rather than the lipids. But all of this is taken to so normal cholesterol on a basic lipid panel is not really as helpful as those more advanced measures. And even with just a basic panel, if you have a PAD or coronary disease, your physician is going to recommend this therapy based on the guidelines.
And when it comes to these statins, it's not just about lowering cholesterol. One vascular surgeon told me that a little known fact is they can also reduce inflammation in the arteries, which may even be more significant.
Absolutely true. We know from the Jupiter trial that HSCRP or high sensitivity C reactive protein will be lowered by the addition of therapy. And those patients who get the most benefit actually get reduction in both their inflammation markers like hsCRP and in their LDL-C. Those were the patients who had the most benefit in that trial. So when we talk about other interventions to lower LDL-C, patients will ask me, well, can't I just do nutritional approaches to lowering LDL-C, or can't I just do supplements that might reduce my LDL-C? To which I say, sure, but those do not have the same reduction event rates based on trials that the statins do. And that may be because of the LDL-C, but it may also be because of these what we call pleiotropic or other effects that these medications have. Biggest one of which, of course, is that lowering of inflammation.
Yeah. My dad, when he was first diagnosed with heart disease, his doctor put him on a statin right away. And my dad said, well, I don't want to be on a statin long term. And he said, I'll make you a deal. Let's put you on a statin until you can actually get all of your risk factors in order. Let's mitigate what might be damaging your arteries, get your diet in check, make sure you're exercising appropriately. And also, let's determine whether or not, and do advanced testing to determine whether or not you have more of a liver production problem or a cholesterol reabsorption problem, which it turns out it was more of a cholesterol reabsorption problem, and he needed to add more fiber to his diet and actually increase the bowel movements he was having each day to excrete the bad cholesterol from his body. And once he got that under control, he's actually been really good ever since, with the threat that he's going back on that statin if it goes out just even by a little marker.
That's a great point. And I think especially right after an acute event, so a heart attack, a limb revascularization, or an acute limb ischemia event, that is really the time to, acknowledge that we need every tool in our arsenal to reduce the inflammation, to stabilize that angry, unstable plaque, or that brand new stent or anastomosis connection in a bypass, and use all those tools. And maybe the answer is we're going to do that temporarily and calm that fire down that's on the inside of that artery wall. And then over time, as we can optimize our nutrition, optimize our exercise and our sleep apnea, get that treated, and do our stress reduction and recovery and all of those things, then yes, we can back down on our medical therapies, assuming everything is going well from, the limb perspective.
Yeah. And there are quite a variety of statins that are available. Would you mind walking us through the different? This is a loaded question, but it's the best we can. You could go on about this for a long time, but the different statins and why the doctors would prescribe one versus another.
Sure. The two that are considered candidates for high intensity statin therapy, the two most recent drugs in the class are rosuvastatin, or Crestor is the brand of that one, and atorvastatin is the other one that we use. So those two would at their higher doses for that high intensity statin therapy that I mentioned. Um, Simvastatin is a drug that I still see many patients on. I don't particularly see a good reason to use it unless they are intolerant to Torva or rosuvastatin. Um, Pitavastatin is kind of a weaker statin. It doesn't create quite as much LDL-C reduction, but it also tends to be the least likely to induce the myalgia or the muscle pain that many patients get. So pitavastatin is sometimes that we will see prescribed for patients that were not able to tolerate even low dose rosuvastatin or atorvastatin.
And probably the newest, I would imagine, is really Repatha. And I heard from an interventional cardiologist that he's seeing incredible outcomes for patients that also have LP little a, which has been known to be a little bit of a thorn in the side of so many patients and so many doctors. What are your thoughts on Repatha, and what are the indications for a patient having those injections?
Sure. So Repatha is actually a different class of medication. It's called a PCSK9 inhibitor, and it's a monoclonal antibody. There are two of the monoclonal antibodies in that group, and then there's now also I believe it's a small interfering RNA that is available that target this PCSK9 molecule in the liver that helps us get that LDL receptor up regulated and clear more of those LDL particles out of circulation. And Repatha and Praluent are both really, really powerful agents. They do not seem to have as many of the side effects as the statin class, and they are absolutely included now as part of our guidelines. If we don't achieve that 50% reduction in LDL-C on maximally tolerated statin therapy, then we are encouraged to add ezetimibe, which is a pill that helps prevent reabsorption of cholesterol in the intestinal tract, and or these PCSK9 inhibitors that are typically administered as a twice monthly injection. They are really powerful agents. We don't, statins tend to slightly increase LP(a). The PCSK9 inhibitors might be neutral. They might lower it a little bit. We are still waiting for the trial results of the dedicated molecules that really do dramatically lower LP(a) levels in the blood, but we don't yet know whether that reduction will result in improved cardiac event rates or even adverse limb events. So we're still waiting on the data for LP(a) agents. They are coming down the pipeline, absolutely. And we know so far that they will dramatically reduce LP(a) levels, but stay tuned for whether that changes our event risk.
Okay, we have so many questions coming in from patients. Let's just get right into them. The first
Do
one
it.
coming in, my father had terrible muscle pain from statins, and I've been diagnosed with P.A.D. Are there any alternatives to statins that work just as well, or ways to minimize the muscle pain if I do have to take them?
Sure. So, in terms of minimizing risk for myalgia, optimizing vitamin D status and CoQ10 status are things that people have done. They are not guideline directed interventions or therapy. They are low risk and potentially high yield interventions to minimize that risk. There are people who will take very low dose statin therapy and seem to be able to tolerate that, but not at higher doses. Myalgia risk can be dose dependent, and you could consider just the a low dose and then adding on either ezetimibe or PCSK. Finally, there is now a new molecule called bempedoic acid that is available to also lower LDL-C and does not seem to be active in the muscles the way that the statins are. So is better tolerated by those patients who have those myalgia symptoms.
Okay, so the next one, I've been on a moderate dose statin for about 6 months since my PAD diagnosis, but I'm still having leg pain when walking. Does this mean the statin isn't working for me?
Good question. So not necessarily. That's going to stabilize the plaque that you have. It is not necessarily going to go away or dramatically reduce that area that's narrowed or blocked. What will do that is walk over time and build that collateral network that we talk so much about here, uh, the PAD association. So that is a slow, long, sometimes process, but I would not expect that the initiation of statin therapy will improve the walking. What I would say is that it will stabilize that plaque so it doesn't get worse, we hope. And over time will slowly build that collateral network. And I tell most patients, you'll probably still have pain with walking, but you may be able to walk further before that happens and require less time to recover. So just managing expectations that that pain won't go away completely, but you may get more distance and you may have shorter recovery as your collateral circulation improves.
Yeah, especially if it lowers the inflammation that's setting your arteries on fire, but might also open up a good discussion for the patient and their doctor on other options such as silostazol or, otherwise known as Pletol, or if they do have diabetes, for example, maybe a semaglutide with the STRIDE trial showing that it can improve walking distance for these patients.
Absolutely.
Okay, next one. I read online that statins can cause diabetes. I already have PAD and I am pre-diabetic. Am I increasing my risk of developing full diabetes by taking statins?
Yeah, answer to that is probably yes. Now, how much are you increasing that risk? That depends a lot on what you are doing nutritionally to manage your glycemic load. what other medications you may be on to help reduce that insulin resistance, and what the dose of your statin is. There is evidence that, especially at high doses, the statins do cause worsening insulin resistance, and there is an incident rate of diabetes. There is some debate about it. People who read the literature debate whether that is really the result of the statins or whether this is a result of the patient population has very prevalent insulin resistance, and whether all of those patients might have gone on to develop diabetes anyway. But my read of the literature is, yes, there is some increased risk. We can probably mitigate that with really aggressive nutritional strategies that help us reduce our insulin burden. And in my practice, I will try to use lower doses. Again, right after a heart attack, right after a limb event, that's not the time probably to go dose on that, especially because it's in violation of our guidelines. But it is a thing we have to balance. And I am very sensitive to that fact because of my passion for the metabolic side of our risk profile. So yeah, it's one of the downsides to these drugs.
And we have a question coming in on YouTube from Nancy. Her husband has a history of hypertension, took 40 milligrams of Lipitor over the course of 40 years. His leg pain is horrific. He was diagnosed 100% bilateral carotid blockages, that's in the neck, and 100% femoral blockages in his legs. He's concerned that the statins, I guess, are increasing the pain. He is 78. The first thing, though, before I would um, have you jump in on that is, Nancy, you can call our Leg Saver hotline later today, 1-833-PAD legs, and let's talk about the conversation that you and your husband should be having with your vascular surgeon about options for treatment, walking as medicine, a supervised exercise therapy program to improve the collateral network of vessels that Dr. Johnston has been talking about, and if you possibly need a second opinion to determine if there are other options that are not currently available to you, available elsewhere as well. But I want to help you make some informed decisions. But to your question, Dr. Johnston?
So when patients who ask me about possible symptoms, I say we should trial you off for a couple of weeks and then go back and keep a diary of your symptoms. If the symptoms don't change when you're off or when you reinitiate the therapy, then it's probably not the statin. And in a patient who has significant arterial disease, it may well be the arterial disease that's causing the statin, but it's and again, because now we have other agents. And so if the muscle pain is coming from statins, then we get box in your chart that says you are intolerant to statins, you've had side effects, and now you can go to your insurance and say, can we please have access to these other more advanced therapies that were Praluent, the PCSK9 inhibitors, to try and keep that LDL at goal without using the thing that causes pain and side effects. But the answer is to go off of it for a brief time and then restart it and see if the symptoms change.
I think you bring up an important point that there is sometimes a progression. There's a you start with one. I always tell people it's just like, and I think most people have experienced this, when you have acid reflux and they start you with the very basic one, and then if that doesn't work over the course of 3 months, then they try you on a different one. Sometimes there are certain rules when it comes to coverage from insurance that says you need to start here. If that doesn't work, you go here, and then you go here, and you need to keep the log, as Dr. Johnston has been talking about, and understand your symptoms, know what's normal for you and what's not, and then make sure you do have a follow-up with your doctor on a regular basis to ensure the medications are working for you and not increasing your symptoms.
Great point. And I tell all my patients when we start medications, this is a trial period. We can reconvene in a few weeks, or usually 4 to and see how things are going. And if you hate it, if you have pain, if you have side effects, then we'll stop it and we'll do something different. This is not a life sentence. This is not something that you have to be on forever. And the side effects are also, if you experience them, then we'll talk about it. And, I don't make anybody do anything. I am here as an educator. I am here to provide options and to tell my patients what we think we know of our scientific ability in the current day and age. But I've had plenty of patients who tell me, I'm not taking that. Okay, it's fine, right? It's your body, it's your choice. You get to make that. I am here to help you with the information, and it may not be the same decision I would make, but that's fine. That's not it is just to provide people the education and the resources to make an informed and a framework to try things with safety, right? And to try things, opportunity to change course if we need to.
And we have Jay Watt on YouTube saying, I'm not on a statin. I do have one stent in my superior mesenteric artery. That's in the gut, right? Um,
Mhm.
they did take Plavix for about a month and now on a daily dose of aspirin. What is the conversation that you would suggest they have with their doctor?
I would ask why the stent was placed, and if it was placed due to plaque in that artery, then that would be a worthwhile thing to discuss. Whether that means that you qualify for that, plan to reduce your cholesterol. There are other reasons to put a stent in the SMA, which might include a dissection. At which point you might not have plaque anywhere else. You might not really need that primary prevention, or even, excuse me, the secondary prevention for somebody with a plaque diagnosis. And then we would just look at your other risk factors and determine whether that was something that was appropriate or not.
Okay, if I completely change my diet, exercise regularly, and lose weight, do you think I can avoid taking statins altogether for my peripheral artery disease? My numbers aren't terrible, but my doctor is insisting.
So again, I have to sort of fall back here on these guidelines. If you have a diagnosis of peripheral arterial disease, the guidelines are going to really recommend that you be on this statin to greater than 50% reduction in your LDL-C, no matter where you're starting. So that doesn't mean you should not go aggressively into nutrition and exercise and stress reduction. All of those things are so important, even if you still have to be, or you're still recommended to be on a statin medication. Ultimately, it will be your choice whether to do to take that medication or not. But what we know is that the medications will reduce adverse cardiac events like heart attack and maybe limb events like amputation. So for those reasons, we will still recommend medication. Maybe it's the LDL-C lowering, but maybe it's those pleiotropic effects, the anti-inflammatory properties that make the difference. And we don't know for sure, but why your doctor is recommending this, even if your numbers aren't terrible, it's just part of line directed therapy. So again, at the end of the day, it is your choice what to do. We are just giving you the best recommendations that science has to offer right now. And I completely understand that that's not very convincing, and nobody wants to be on these medications forever. This is kind of where we are, and you have to decision what works best for you.
And Jaywan just followed up and said that she's an 80-year-old woman. Good for her. She's doing great. 80 years old. Oh my goodness. That's amazing. Keep walking, keep walking, keep walking. Push yourself. Go, 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 go. You're doing great. And then Nancy also thanked you for the great information that you provided. Both are tuning in on YouTube. Make sure that if you are on our YouTube channel, make sure to like the video and subscribe to our channel so that YouTube will push this video further so more people get this amazing information that Dr. Johnston is providing. Okay, let's see here. Another question coming in. My doctor wants me to take a high intensity statin after my recent P.A.D. diagnosis, but I'm worried about memory problems. Is cognitive decline a real side effect, and should I be concerned at age 68?
This a lot as a question and a concern. There have been a couple of case reports of individual patients who've had severe cognitive issues after initiation of statin therapy. Those were reversible the minute they stopped, several days after they stopped that statin therapy. And we do that there are certain people who are more susceptible to this than others, and that might be detectable on some advanced lipid testing in terms of desmosterol and other things. But overwhelmingly, this is not a side effect that we see. Probably statins contribute to a reduced risk of dementia over time, probably related to reduced vascular dementia, reduced stroke rate, or silent strokes. Uh, Generally speaking, I am not concerned that impairment is going to be a side effect for my patients. If it is reversible. If you stop your statin, it should go away. We can then call it intolerance and move on to other therapies. But overwhelmingly, the answer is no. It does not cause cognitive impairment. There have been multiple randomized trials and effective series that have looked for this and have not been able to find a signal over patients. So generally speaking, no. The other thing you could do is ask for um, the less lipophilic statin. So rosuvastatin, a little bit more soluble in water. It is less likely to cross the blood-brain barrier, we believe, than atorvastatin. That is probably, it's not as well supported by evidence, but most of us sort of prefer the rosuvastatin for that reason, and would be a little less likely to cause any cognitive issues.
Sorry for the distraction. That was our Lifesaver hotline. So no matter, we have our team there answering the phone lines. You can see the Lifesaver hotline behind me. We do have a team that's answering those, but every single call always rings as well to me. So I make sure that I'm on top of, how many times the phone's ringing, making sure my team's on top of it and answering the calls and getting to every single person who is calling to ask questions about P.A.D. and for any sort of support with P.A.D. That we are getting to your questions and your concerns in real time. So sorry about the distraction there. Jumping in case you heard the phone ringing over and over. We had 2 calls coming in simultaneously, and I wanted to make sure they were answered.
Wow.
So back to our conversation here. Okay, I've been on Lipitor for my PAD, but keep reading about CoQ10 depletion. Should I be taking CoQ10 supplements with my statin? And will that help with the fatigue I've been experiencing? I'd like to follow up before you answer that. We did have an interventional cardiologist on just the other day who says that he always tells patients to take it, but did not know that there's actually a CoQ10 blood test. I don't know how readily available that is, but I know when my parents were dealing with statins and things, that was something that we had regularly tested so that their functional medicine practitioner and cardiologist would come together in agreement as to how much CoQ10 they should be taking along with the statin.
Hmm. Yeah, I check it fairly frequently in my patients, although not always. And all I do always recommend that CoQ10 be a supplement that patients look into if they are on statin therapy. Typically, that dose would be 100. I think it's milligrams, or maybe it's micrograms. I don't remember. It's about usually 100 twice a day, and that's better absorption than 200 once a day. So I do think the CoQ10 depletion is an issue, and supplementing it is low risk, high reward. Not terribly well supported by the evidence, but again, low risk of harm and something to consider. Whether it will resolve fatigue, I don't know, but it's worth a shot.
And thank you to Joe letting me know that you didn't hear the phone, so you all think I'm actually cuckoo crazy, but the phone was ringing. I guess you couldn't hear it on your end. So that's actually good to know that it's not a distraction for everyone here. The next question is, are there certain statins that work better specifically, good question here, specifically for PAD compared to ones prescribed mainly for heart disease? My friend with heart issues takes a different one than me.
Not as far as we know. So high intensity statin therapy is rosuvastatin or atorvastatin, and it is the same for PAD as coronary artery disease. And it's a systemic disease, so that kind of makes sense. The plaque that forms arteries in the heart is the same plaque that forms in the arteries in the legs or in the neck or in, so it really ought to be the same. And best we know, we use the same one.
But different doctors might prescribe different statins just based on what they have experienced, even with their own patients. It also may come down to what insurance you have, what they cover. So there are a lot of different factors that may end up um, being the reason for one particular statin being prescribed for one person versus another, right?
Correct.
Okay. I've been experiencing what I think are statin side effects, but my doctor seems very dismissive. How can I tell if what I'm experiencing is actually from the statin or just coincidence and aging?
Again, I would recommend stopping for 2 weeks, keeping a diary of your symptoms before you stop, then during that washout period of a couple of weeks, and then restarting and seeing what changes with your symptoms. And if you don't really notice a big difference on versus off, then it may not be statin. If you do notice a significant change and improvement when you're off the statin and then it all comes back immediately when you restart that medication, then I would say that's a more convincing argument that the symptoms are related to medication. And now you have some evidence to go back to your doctor with, where you can say, look, here are my symptom diaries, and this is when I stopped, this is when I started. It all came right back. And can we talk about an alternative medication?
And if statins are so important for PAD, why did my leg pain actually get worse after starting them? I thought they were supposed to improve circulation and symptoms. I know you addressed this already, but different people have different phrasing, and so I think it's important to still address this question as well.
Yeah, fundamentally, the statins are not directed at symptoms. The statin directed at preventing the narrowing or blockage that you already have from getting, particularly as it relates to any narrowings you may have in the circulation, the coronary arteries, in the brain, the carotid circulation, or even higher in the brain itself, and maybe the other leg or other areas, right? If you have an occlusion somewhere, obviously that's not going to go away, but there will be other vascular beds, other areas where you do have narrowing or disease. And the job of the statins to prevent that from getting worse, to prevent you from dying of a heart attack, of a stroke, or having another limb ischemia event. And over time with walking, you may be able to improve the symptoms, but maybe not. And I think this is another opportunity to reiterate that aspirin and statin therapy are guideline directed and they are important, but they are almost never sufficient to help manage the risk factors for this disease. So if your diabetes is not well controlled, if your inflammation is still high despite high intensity statin therapy, if your homocysteine is elevated, if your LP little a is high, there are so many other things that also contribute to the progression of plaque that, the reason so many people have lost faith, in my opinion, in our medical management is because it's not enough, right? The statins, yes, they're guideline directed, they are important, they do reduce cardiac events and limb events, but not completely, not to the degree that everybody thinks. And so when people say, I still have pain, I still had a heart attack, why am I even on this medication? Then I understand that. That's that deep frustration. I did what I was told and I still had a bad outcome. And I think that's because we as the medical profession have not gotten sophisticated enough as a whole in terms of managing all the other things that also contribute to ongoing progression of plaque or atherosclerosis. So, even though I'm spending all this time talking about the statin, that is a small part of what I do in my practice because it's not enough for most people. So, it breaks my heart when people say my symptoms are worse. I'm doing what the doctor said. I don't believe in this anymore. Like, yeah, it doesn't mean it's not important, but it may mean that it's not enough.
It's a Band-Aid. It's part of guidelines. It is necessary for so many patients, but you bring up such an important point that you got to get to the root cause. What is damaging your arteries in the first place? What is irritating those arteries? What's leading to the plaque buildup? What's really going on? And that is the conversation, not whether or not you should be taking a statin. The conversation should dig deeper. It should be, doctor, let's sit and let's map out all of the different reasons why I may be having these issues with plaque building up. It could be family history, but with family history, there might be hypercoagulability. Do you need a referral to a hematologist to find out if you have protein S or factor 5 Leiden or factor 11, or if you have the MTHFR mutation? You mentioned the homocysteine levels. That's an enzyme in the blood that if it's elevated, then it's like nails on your artery walls. It's causing damage. And a simple methylated B vitamin could really help you resolve that problem. But you have to have that conversation with your doctor, and a doctor like Dr. Lily Johnston, who really is passionate about metabolic health, right?
That's certainly my prejudice.
And Nancy is asking, did you say there is an injectable statin?
There is an injectable cholesterol lowering medication. They are technically not a statin. They are called PCSK9 inhibitor. The brand names are Repatha or Praluent, um, alirocumab, and evolocumab are the the generic names for those. They do similar things as the statin class of medications, but they have a different mechanism of action. We are using them more and more in patients who are not tolerant to statins or do not have the desired lipid lowering effect from their statin.
PT 103, how have guidelines for these drugs changed over the past 5 years?
So the most recent set of guidelines come from the American College of Cardiology, the American Heart Association, and the Society for Vascular Surgery was a signatory to those guidelines. Those came out in 2024. So this is where the definition of high intensity statins was adjusted, right, to include both rosuvastatin and atorvastatin. And we created that goal of greater than 50% lowering with a beyond that a goal of less than 70 milligrams per deciliter, and the use of the addition of ezetimibe and the PCSK9 inhibitors to achieve that if maximally tolerated statin therapy does not achieve that greater than 50% reduction or less than 70 per deciliter of LDL-C.
We got a good question coming in. Another good question. I take several medications for different conditions along with my statin for P.A.D. Are there specific drug interactions that I should be concerned about that might not be obvious to my doctors?
I would say that's a great question for your pharmacist. They tend to be the most savvy of drug-drug interactions. I can't speak to that, of course, without knowing the other medication. The only thing to know for sure is that, for patients who have impaired liver function or kidney function, the dosages or the themselves might be changed depending on those things. But I would ask your pharmacist. They tend to be very savvy about those kinds of.
And we have a question that's coming in about red yeast rice. Why can't, if it's made from that, why can't I just go to Amazon and get that?
Mm, several parts. So, can you take red yeast rice and achieve LDL-C low? Red yeast rice does kind of the origin of the original molecule. It is not quite as powerful as the high intensity statin we've just been discussing, but it will lower LDL-C. Getting it from Amazon, favorite option because I don't know who made it or whether it's been third party tested and there are heavy metals in it, or whether what's in it is really red yeast rice or something else selling, could be cornstarch for all you know. So if you're going to get it, I would not recommend Amazon source. And the last thing I'll say is we don't have outcomes data on red yeast rice, major adverse cardiac events or major adverse limb events to the same extent that we do for the statins. And whether it has those same pleiotropic effects like lowering inflammation that we do know exist. But if you're not going to take high intensity statin therapy, it's just harder for you, but you are willing to take red yeast rice, is that an acceptable substitute for you? It might be, right? Is some better than none? Maybe. And that is a conversation that you should have with, perhaps an integrative cardiologist. We also have, citrus bergamot. We have a number of supplements that can reduce LDL-C. We do not have outcomes data that they will reduce your cardiac event risk or your risk of limb loss. We just don't have those data. And if that's what you're willing to do and that's what you think makes for you, okay, let's then find you a high quality, third party tested source of that supplement. Make sure that we are being as safe and efficacious as we can be with that approach.
And the final question that I have coming in is just critical questions to ask your doctor. So I've been diagnosed with PAD. You want to put me on a statin. What question should I ask before I go to the pharmacy and pick it up?
I think, question is just making sure you understand that diagnosis and side effects might there be? Are there alternative medications? What is this plan? Are we ever going to reduce it? What are you looking for in terms of my labs? Should we make sure that I have a baseline set of labs and that advanced lipid testing? And then how soon are we going to follow up? In today's era of the guideline directed therapy, the most important question is when are we going to check again and make changes to that therapy? It's not enough. I see a lot of patients who end up on aspirin statin and never get reevaluated or that we are achieving that greater than 50% reduction in LDL-C. And if you're a patient that doesn't believe that that's going to be helpful for you, then that's fine. But for the rest, my patients who are willing to do everything to make sure that we, get that guideline directed therapy and we do everything possible to reduce their chance of losing a limb, I would say I would recheck in 6 weeks or 8 weeks, see if we're getting that greater than 50% reduction. And if not, then we decide if we're going to escalate therapy, add a second agent like ezetimibe and see what that gets us and then go from there.
It's interesting. We have an advisor who's a pharmacist, and she always tells, our patients that you need to always, if you're on medications, you need to have an appointment every 6 months for life just to go over your medications and to get another set of blood work to ensure the medications are still appropriate for your particular presentation of disease, no matter what it might be. But then it also, you have the opportunity to discuss any symptoms, anything that may have changed over the last 6 months that may require, for example, an added supplement for nutrient deficiencies that they may cause. Because, as you mentioned earlier, these statins can actually deplete CoQ10 levels. And so it's really important to say to your doctor, hey, let's have a follow up appointment every 6 months. Let's check some of the key, mineral and vitamin levels and any other levels that might be important, cholesterol levels, to determine that whether or not I'm on the right course of medication and have the right care plan for me continuing forward.
Yeah, so important.
Awesome. Thank you so much, Dr. Lily Johnston. Any final thoughts on statins before we close out? I know we're going to end up having to do a follow up on this. That might end up being what we do next week, is just another one on statins, just because I have a feeling that this is going to generate an even grander conversation that we'll want to make sure that we address all questions that are coming in, because it's such an important topic and there's so many people talking about it and so much misinformation out there. Well, just so much information altogether that I think that we'll need to just have a follow up. And so people know, if they are tuning in to this one, that they didn't lose an opportunity to ask you the questions that they do want to ask about statins.
Sure. And I think, just having an opportunity to discuss these concerns with us here at the Global P.A.D. Association or your physician, right? Most people are happy to get that information and they just want not that they're opposed to the medication. They've just heard a lot of things and they have a lot of questions. This opportunity to go through that, have this kind of, then, feel more confident in whatever choice you make moving forward.
Thank you so much. And you're at a conference right now. Have you been to any of the sessions yet? We're going to leave you to go to the conference, but anything that you've heard or learned, or anything you're most excited about, tell us about this conference as we close out here.
I am here in sunny Ojai, California, the Western Vascular Surgery meeting. So I am about to go learn a bunch. Stay tuned.
Fantastic. We'll see you next week, Dr. Johnston. Thanks everyone for joining us. Make sure if you have further questions or you want to talk to someone about P.A.D., call our Leg Saver hotline, 1-833-PAD legs. That's 723-5347. Looks like we may be continuing the conversation on statins next week. So never fear if you didn't get your questions in this week. We will do a follow-up next week and just make sure that everyone's comfortable with where they're at and the questions that they have for their care team. To make sure that you're on the right course of action for you. Don't forget, like this video, subscribe to our channel. Have a great week, everyone.
Take good care. Thank you.